physical activity guidelines. And for me, I guess I struggle with like the scope of like being a PT, and okay, then maybe you're a coach as well. But like, I just like, and there's always going to be like a selection bias, like what your exposure to a population is. But I feel like it's really hard. It gave me flashbacks to like, did you guys ever do like the presidential fitness challenge when you were in like elementary school?
Hmm.
And you had to like climb that rope, and that was the worst one of all of them. But it's like, I feel like we don't have like that emphasis even starting out, like as kids. I don't know, and it's just hard for like the scope of PT and like how that applies to like reaching a broader audience. I kind of struggled and like was questioning that, trying to read through these papers and make sense of that.
So can you elaborate on what you mean by like struggling with that, or where you feel our scope stops?
Yeah, I guess I was kind of thinking of it more in like a traditional, well, really in a like traditional outpatient setting.
Hmm.
There's a selection bias that's going to be coming to you, probably pain related, maybe surgically related,
Hmm.
um, but there's that broader issue of physical inactivity. And I guess while I was reading it, I was more curious about like what your thoughts are in how to reach a broader audience as a PT.
Well, for reaching a broader audience, I think like one thing that they don't really teach you, or I don't think we learn about in school, is like scale. And PT has kind of a rate limiting step in the traditional sense of like you can only see one patient at a time, or two if you double book. Um, Whereas, so that tops you out in an 8-hour day at like, let's say worst case scenario, 25 patients. So, even if you think about it, like I've probably had that day 3 times in my career and probably cussed the entire time. But like, it's even then, like I'm talking to a very, very, very small portion of society. So you do have to do things where you're getting out and being advocates. I mean, if you would have told me that I would be on Instagram as much as I am 10 years ago, I would have laughed in your face. But really, like, if you want to get the good word out, that's kind of where you need to aim a little bit.
Based off
Uh,
that, even with Instagram, do you think you're probably mainly talking to the people who already meet these guidelines?
um, no, actually, I get messages on a fairly regular occasion whenever I go off on these, of someone that's like, "Well, I didn't know that," and on top of that, I feel some of my account activity on the internet is much more like focused towards clinicians, and like it's a little sad how many clinicians don't know the physical activity guidelines. They can tell you the origin and insertion of the obturator internus, but they can't tell you how much you should get off a couch and move around. And like, if you ask me which one of those are higher yield, I mean, I think I disclosed that with my tone right there. But even to your point about these conversations in clinic, like I don't give a shit what exercise you do if you're meeting physical activity guidelines. Like, and I think that's been something that's kind of shifted, because it is really easy to laugh when you see the video of the lady out prancercising. But like, she's having a good time. She's getting 30 minutes in 3 times a week. Good on you. Like and I think like I've kind of shifted that view out of it. And it really is having these conversations with patients of like, well, what do you want to do? Like I work for a company called Barbell Medicine. So obviously like my propensity is to get you strength trained. But if you don't want to strength train, cool. Let's talk about if you want to LARP. Like once again, if you're being active, I don't care what you do.
I think when I was in school, also I kind of had this idea that maybe wasn't necessarily in our realm to kind of advocate for that sort of thing, because I guess I thought as physical therapists, we were supposed to like fix people's pain or something like that. And I guess since I've gotten out, I've kind of realized that we do have a pretty good platform to stand on, even if it's just a small audience with like Derek was saying, 12 to 25 patients that you're seeing a day. I think trying to be an advocate for it with each one of them is a pretty good place to start. And it doesn't necessarily have to be like meeting that 150 minutes every single week, but like starting with something that they can do now. I like how in the article it talked about how like literally just like 15 minutes a day could be the first place to start. I think
Yeah,
that's
I think
what I try to get across to every patient that I talk to is at least participate in some form of physical activity throughout the week.
Yeah, I think the art and paper is really good because especially there's the one figure that's in there where he makes I think it's a he, now I'm questioning, figure 4 in the paper where they're talking about like, if we make this arbitrary cutoff of 150 minutes, all of a sudden we should see this huge drop off in comorbidities. It just doesn't work like that. There is that slow decline out of it. And it's really, I think getting into this has been a little bit eye-opening for me as well, because I'm definitely one of those individuals that loves making fun of the exercise that's included in randomized controlled trials for PTs and how like blatantly stupid and underdosed a lot of it is, but like it tends to work. And if you look at the fact of 40% of the population isn't doing any physical activity, well, hell, if I give you 20 quad sets, 20 glute bridges, and 20 step ups, like we've infinitely increased your physical activity. But like, is that really the bar we should be aiming for, or should we try and get people more active along the way? And like, this is going to come off very homer towards our profession, but like, if you look at the money we invest in trying to create some cure for diabetes or cardiovascular disease, and like then you look at just being more active reduces the incidence at such a level that like we would save billions of dollars, why are we not shooting for the low-hanging fruit?
And I feel like we kind of touched on that shift in focus for the PT profession as like being the movement experts,
Fuck
which
that.
that's a whole another rabbit hole. Yeah, that was the air quotes. Please don't smite me. But I feel like we kind of talked about that, like in shifting towards like a preventative approach. Like we can have that superpower of like absolutely preventing injury. But like talking about moving more towards like a preventative, like proactive measure versus like the reimbursement model, you're injured and we're rehabbing you on the backside of an injury.
So
But I just
go
don't
ahead.
see that happening, like as far as like the way reimbursement, if we're talking insurance, and that's a whole nother mess, but like how do we get out in front of it? I guess that is taking on, as it stands, like a coaching role or trying to advocate just more for physical activity.
Well, so there's kind of a lot to unpack there. I'm going to work backwards through it just because, like, so let's look. If you see someone for a tendinopathy, how long does tendon take to turn over?
I'm gonna phone a friend, Alex. Like 6 to 8 weeks.
I was going to say 6 to 8 weeks. I don't remember I don't know the exact number. But.
So if you want a really fun study to go look at, PubMed nuclear bomb and tendon. And there are some studies where they've looked at basically when they were testing a bunch of the nuclear bombs back in the early 50s, there was more radioactive material in there. And they've basically shown that tendon turnover is abysmally slow, and it's often in these studies they showed that after 18 there's just not a lot of tendon turnover. But I would argue this kind of is the same trope as the discs healing. Like if you're not active, you can't really be surprised that shit doesn't heal. But if you look at a lot of Magnuson's papers, like tendon, you're talking on the order of months. So if that's the case, if you see someone for 6 weeks, you didn't do shit for the actual physiology of their tendon. So what are you really changing? You're modifying their load, and in best case scenario, you're working on changing some behaviors. And like if you want a low hanging fruit goal at this point, like there is a ton of evidence for these physical activity guidelines being beneficial. And I've started writing in goals for a lot of my patients to say patient will meet baseline physical activity guidelines of 150 minutes of moderate level physical activity. Now, if you want to talk about a goal, you can take the insurance and be like, hey, high yield, like you can really stand on that one.
I had a question that kind of pertains to that too, Derek. So I guess with all the stuff that we know that's coming out with like low back pain, and how pretty much like any sort of exercise intervention can be somewhat effective in helping reduce it, and just because of the general return to baseline that people are going to experience with it over time. I mean, it's almost kind of like killing two birds with one stone, where you could recommend really anything that the patient wants to do. It could be like aerobic activity, could be weight training, something like that, and basically kind of getting that in, but also treating it as rehab. I don't know. I feel like I have some coworkers that I work with that think that sometimes whenever I give patients an intervention for low back pain, that may not be like, as specific as they think it should be towards like that actual pain that they're experiencing or something like that, that it's not going to be any better than something that they would do. You know what I mean?
I mean, I would say let's play a game. We'll check our oswestries on my patients versus your patients. And, there is no real evidence for any specific exercise. And I think that's something that PTs struggle with in general, because how we're taught is this very X plus Y equals Z. Like, problem arises, this is intervention, outcome is this. When you look at it, like a lot more of this is very probability based. Like, so if you look at an average 40-year-old, if we do an MRI, has a 60% chance of a disc herniation. Now, if you look at the papers, there is a higher probability of that individual being symptomatic. So if they are symptomatic, then I need to modify those symptoms. Well, if you look at pick an intervention, motor control exercises have crap for evidence behind them. So let's say there's a 20% probability they're going to get relief out of that. Actually, natural history is 50%. So let's just say there's 50% probability. So now we're at 60% with a little bit on the top for that additional, multiplied by a 50% chance of regression to the mean. And then we haven't even talked to them about their sleep or, their overall mental health. So there's some other percentages getting factored in. And like, this isn't a yes, no thing. Like, we're living so far in the gray with all of this. Like, I mean, so think about it like this. So you work in outpatient orthopedics, I'm assuming, right?
I do, yeah.
What percentage of your patients do you think get better?
60, 70% maybe.
So if you look at the data, that's about where we hit. So, and I think, what we're looking to do basically is like, if you want to be a really good therapist, you're not moving to 100%. You're probably moving to like 80, 83. So that still means 1 out of 5 people probably isn't going to have a phenomenal outcome. So back to our like awful day at the clinic, if you're, God forbid, seeing 25 patients in a day, that's 5 people that probably aren't going to have a positive outcome. Now, I would argue if you're seeing 25 in a day, it's probably closer to 7 or 8, because you're probably hedging your outcomes down a little bit lower. But this isn't like a well, I palpated this and I can intervene on this thing. There's way too many layers to this. And like, if you're not meeting basic physical activity guidelines, like, you know, I think it would be hilarious. Like, all of us would laugh if somebody went to a nutritionist and they're like, well, doc, my kcal consumption a day is 7,000 calories, and most of it's through Doritos and you know, cheeseburgers. But, you know, I really want to talk about this supplement and this B vitamin I want to take. And like, you know, that's objectively hilarious and a waste of conversation. But it's no different from like, I sit on my ass for 18 hours a day and I need to know that one weird trick exercise is going to fix my low back pain.
What has changed in, and I know you've said for the insurance, you've kind of written in those goals, the 150 minutes. What
Wait a
if,
second, I'm going to go throw my dog back inside.
surely.
I can still hear you.
Okay. What if you changed in regards to a patient comes in and they are very sedentary and you are very kind of liberal in what you would want them to do from a physical activity standpoint? What do you say at that point? Like, whatever you enjoy doing, continue to do that? Or do you feel like they still need guidance? Because obviously if they're sedentary, they're not doing anything. Like, how do you go about that with people that really don't have any guidance at the moment?
Sometimes it's not even enjoy in the beginning. Like, I'll start by framing it through, like, I mean, if you want to have some fun with your middle-aged people, you want to have a good conversation. Well, you want to play with your grandkids as they get older, right? They're not going to get any smaller. So, you know, when they're in that 40, 50 pound range, you may not be able to be as active with them as you want to be. And you want to do that, right? Like, and I had a lady in Florida who had pain just walking to her mailbox and back. And we got her going. She started improving, and then she went and walked like 4 miles at Disney and came in and like was obviously hurting. And she was like, I'm just back at square one. I'm like, no, you're not. Like, 3 months ago, would you have even thought about going to Disney? She's like, well, no. I'm like, well, you did it. Like, you had enough confidence in your knees to where you thought you could go do that. Like, that in and of itself is a huge step in the right direction. So it's not like there is this special exercise. It's having these, and in fact, like, you know, I keep using the word exercise, but there's some papers, especially for the older population, to where you're better off just talking about movement. Because let's face it, like, if any of you guys have older parents, I challenge you to go start talking to them about exercise and see how that conversation goes.
Yeah, in our first semester, we took ex-phys and we were just like shoved down the throat with physical activity guidelines, which is good because we know them, but we would write out like prescriptions of population, like how would we fit this into their weekly plan. And then my realization was you have a patient potentially who's doing nothing, and then you need them to fit this 150 minutes a week and potentially twice a week of muscle strengthening. It's like, that is such a huge kind of change in their lifestyle that it's, once you look at it on paper, you're like, how is this realistic at all? And we never really had that discussion of how do you kind of slowly ramp these things up. And like what you talked about in your barbell medicine research review of like these kind of, was it like low and liberal versus high and stringent, and like where's a good starting point, or where's this a minimum effect, and then kind of where's that end goal of 150 and 2 times a week of muscle strengthening.
Well, and it's not like there's, once again, back to the figure 4 out of the Arden paper, it's not like there's some magical thing that opens there. But, you know, to that paper, and that paper basically, for those of you who are unfamiliar with it, took individuals and like asked them their own physical activity guidelines, and then or their own physical activity participation, and then showed them either a very stringent set of physical activity guidelines or a very liberal, and then asked them to kind of reflect on their own physical activity participation. And the people who were shown the really stringent had a lower self-efficacy of their own activity. And if you think about it, like if we're trying to get people more active, we don't want a low self-efficacy out of that. So we may be like shooting ourselves in the foot, like coming out of the gate and being like, you're not doing anything. We need 150 minutes. It's like, no, we need something. And then we can start talking about the actual parameters that we need to do. And it's not like, 150 minutes is still like the minimum recommendation. And there obviously, like, there's only so many hours in the day, but like, if you really think about it over the course of a week, 2.5 hours of physical activity isn't a whole lot. And, we look at all these tropes like, well, I used to be able to do this in high school. Well, cool. That was 20 years ago. When's the last time you had a bout of 100 jumps in any training session? Well, why are you that surprised that your knee hurt when you went out and played in a 5-game basketball tournament? Like, it really is like, if you continue to change these behaviors, you adapt to them. And I think we miss the boat a lot on the way we frame it, what we see as good and bad. Like, there aren't good or bad movements. There aren't like, it's like investing. Like, I'm pretty sure none of us are ever going to look in our 401k and be like, you know what, I'm rich enough. And physical activity really is the same thing. But like, if I came out and said, in order for you to comfortably retire, you need $2 million, and you guys haven't even opened up an account, a lot of people are just going to go like, screw it, not going to get there anyway. And it really is like the same compounding interest. Like the things that are really daunting in the beginning end up adding up over time. Like, it's, if you look at a 600-pound squatter, like, it's awesome they can do 600 pounds. But think about how many more reps that they have at 135 warming up than you probably have as whatever you squat, because they've been so consistent in their training. And I think we forget that part of it, because all we ever look at is the top end stuff, like the results.
And I had a question about the paper as well. I think, or I just kind of wanted to clarify. I think in one part it was talking also about how the barrier for added benefit is like even lower than what we think it is. I think this was kind of my understanding. Tell me if you think that this was kind of how you interpret it as well. But basically, that 150 minutes was an accumulation of evidence that's kind of been based primarily on self-reported data, and what we already know that's pretty fudged in itself. And so whenever it was looking at how much people actually performed whenever they put the accelerometers on them or whatever to track their physical activity, that they were meeting way lower than that, but they were still getting good benefit from it. So that 150 minutes isn't even really it's not even like a minute. Like, you could do less than that and still get pretty good benefit. So if that's where you were trying to have somebody start, they could still start making, I guess, gains in that area.
So if you look at figure 5 in that paper, even if you're doing half of the recommendation, you still get a 20% reduction in risk. And so like it's diminished. So if you're half of it, you get 20%. If you meet it, you're at 31%. If you exceed it, you're at 37%. So like it's still, once again, we're back in this whole percentage thing. So this isn't like if you do it, all of a sudden the physical activity gods will come down upon you and confer to you everlasting health. So
Do you think that even if they hit like a quarter of that kind of goal of 150, or if that's kind of what we create lower standards or lower barriers to entry. Do you think that's would be enough of a change for people to actually do stuff?
I mean, I think there shouldn't be any barrier to entry is the biggest thing. In like, I think a lot of those we self-impose, and it's like, so one of the studies that I think is one of the most geniusly designed things of all time, Ellen Langer did a study that they looked at hotel workers, and they asked them how much physical activity they thought they got, and they were all like, well, we're not very active in general, and their overall mental health just outcomes weren't that great as well. And if you've ever cleaned your house for 3 hours, there's a lot of physical labor involved in that. So then they had a discussion. They're like, well, you guys aren't just like meeting physical activity guidelines, you're actually exceeding them. And like people started having like, or they started having like more like positive self-efficacy and looking at the way they were being active. And I think like having those conversations about what constitutes activity is like a huge thing. And then so let's take it kind of the other extreme. Let's say you have a coal miner. You guys are in Texas. Let's say you have a ranch hand on your schedule who's out working cattle for 10 hours a day. And so he's obviously meeting physical activity guidelines. Well, what's our other big high yield thing for health? Sleep. So like with that individual, I'm going to be like, hey dude, like how you sleeping? Well, I'll get like 4.5 hours a night. Ain't no exercise going to fix you more than you doing supine, side lying, head into pillow for 8 hours. And like this is that whole like overcomplicating thing. Like if you're not being active, that's step one. Are you getting the adequate amount of sleep? Step two. Like I tend to be remiss to have some nutrition conversations just because like I don't feel that qualified for it. But occasionally I'll go down that rabbit hole. But like if you're not checking those 3 boxes, like I do not care like the minutia of how you're moving. Like how can you be a movement systems expert when the vast majority of society is not moving?
So let's say you have, I mean, I would say in most outpatient ortho clinics, what you said, like those big rocks, none of them are achieving. Where is this balance of I'm inherently providing such a little change compared to what they could be doing from a sleep or just physical, like weekly physical activity standpoint? Besides educating them, is there really a point? What is the point like as a PT, if that makes sense?
But so this gets into some of the stuff that we're starting to see emerge in physical therapy related to like cognitive behavioral therapy, motivational interviewing. And it really is trying to affect that behavior change side of it. And like, it's hard, but it's also being able to have conversations with people. And I'm going to murder my dog. So if you look at a lot of it, it is like meeting that person where they're at and talking to them. And there's a phenomenal paper by Diane Jacobs and Jason Silvernail on operator versus interactor. And I think a lot of physical therapists really see themselves as operators. You're working on fixing someone. Whereas that's not how we should approach it. We should be much more approaching it as someone who's interacting with another person. Like all of us on here, I'm assuming, have been in relationships. And what's the best way to get your significant other to calm down? It's obviously to tell them to calm down. Like you have to be able to like figure out how to have that conversation in order to like get that end result out of it. And like to take that analogy full swing, as you're learning to do that, you're going to sleep on the couch a few times. Like you're not going to nail these conversations out of the gate. But what happens is, and Chris, you know, you've seen me treat, like, one of my litmuses for like having students stop watching me do evaluations is when they figure out that I end up just saying different riffs of the same thing over and over again. And it really is because I've had so many reps now of like, well, that didn't work, let me try it this way. And so it's gotten a little bit more scripted into like my personality and what I need to say. But that's only come with, you know, God knows how many repetitions at this point in my career. And I think that's the hard part. Like, there definitely is that experience side of it, but that experience side of it is like often predicated off of making mistakes.
Uh, Derek, I was just kind of thinking back to like where, and obviously it depends on the patient. But as far, we've been given the recommendation that like if your patient is completely inactive, you know, park in the farthest spot at the grocery store. And 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 Chris and I have talked about this. It's like kind of a mental challenge because okay, that is an increase over what they've currently been doing, but at the same time, it's just like it just seems so low dose, like drop in the ocean, almost like as far as trying to create like true behavior change, conditioning effects. But I don't know. Is there? Okay, that's an ultimatum. I don't know. What are your thoughts on like where do you start someone if they are completely inactive? I guess it's probably based off their goals, what they like to do, and then just trying to build something incrementally towards that.
I mean, I don't think it's up to me on where I start them. I need to figure out where we need to start. Like, if you listen to a lot of my patient interactions, like, I very intentionally use the royal we a lot because I want it to be something that we're collaborating on, as opposed to me just saying like, yeah, go park in the parking spot in San Antonio, Texas in June, because we all know people are going to go do that. Like, it's just like, yeah, like the solution you're proposing at face value is absolutely accurate, but no one's going to do it. And like, we need to be finding these things that people will do. And you only really learn that from like talking to people about what they're willing to do. I mean, think about it from the other extreme. Like, if I got hurt and I went to a physical therapist and they were like, yeah, you need to stop lifting weights, I would laugh in their face. But like, let's say I actually did need to like stop doing something for a little while. Like, the advice you gave was objectively correct, but it certainly is not going to get the outcome that you were looking for.
If you had the ability to change what the guidelines said or how they were phrased, have you thought about like, would you make it more specific, less specific? Would you have like categories of populations?
So I think the guidelines are perfect. I think it's how we implement the guidelines is the problem. Because really, if you want to confer a lot of these benefits, you need to be more active. But you think about it, it's one thing for us to know the guidelines. And back to my like investment thing, like if I as a financial advisor know you need to invest $2 million in order to retire at the level you want to, like, leading with that is probably not the best way. Like, you want to have something to be scaled to where like the entrance, and you can say like, look, this is where we're aiming, but we have to start here. And I think coming out and just like saying, well, you have to get 150 minutes a week, that's just like using a sledgehammer when like we're not even quite ready to do the work yet. Quentin, I know something's going on in that mind of yours, man.
Yeah, I finally got my video and audio to work, so that's good. Yeah, no, I was just thinking so I'm at the VA, and at the VA there are so many patients with comorbidities that like even doing the sleeping part, they can't sleep. They have crazy PTSD. They've got all kinds of mental health challenges, and the pain that they experience, I mean, it's like wading through red flag and yellow flag. There's nothing else. You're just like everything. Oh yeah, I have night sweats. Yeah, I have tons of night pain that wakes me up at night. Yeah, I maybe sleep for, I don't know, maybe 30 minutes at a time. Then I wake up in pain and I have to take some opioids and then I can get back to sleep. They're being seen by like 1,000 different doctors, it seems like sometimes. This isn't everyone, but this happens quite frequently that it's like, holy crap, there's a lot of your story going on here, and the big rocks that I want to put in the basket first, like, are so difficult. So going back to maybe Kevin's point and Chris with like what you're asking with the physical activity, sometimes with patients like that, it really is just finding the very, very bare minimum thing that can be salient to them that they can do that I feel like would help, and just traveling that path and and seeing what happens. And honestly, a lot of the time, so much of it is psychological that you just give them like the bare minimum dose of something that they care about, and you notice like between the next 3 4th visit, things in their life are starting to improve, and then they like start talking to you more about, yeah, hey, I actually like went down to the mailbox today. Yeah, I actually I went down and talked to my neighbor for the first time who lives 2 doors down. So I don't think, going back to that point, like, I don't think that even just the amount of walking into the grocery store that you were talking about is really the problem. I think the actual amount of physical activity that would be doing might be appropriate for some. It's just more kind of what Derek was saying, like, it has to mean something to them. It has to be something that's accessible, something they can repeat and continue to do without you being there, if that makes sense.
Yeah, I guess that's like the inexperience of like being a second year with no like clinical experience, but kind of even what Derek was saying, like in the like what will they agree to do? And I guess that goes into like the repeatability and like the baseline of like patient acceptance to have a behavior change. Like obviously you can't just like dump it on top of them and then say, here you go. Like that's similar to just like dumping research on someone, like like a patient with research. But I like that idea of just they're, especially with that population, and I guess it's with every population, you just find what their entry level is, and maybe some of that's like motivational interviewing as well, just to help them discover where their entry point is.
Yeah, something have you guys read The Art and Science of Lifting from Greg Nuckols? Tomorrow, ISIF, that came out. I don't know. Some of you might. Derek, have you?
No.
Yeah, if you look at it, there's just on the art of lifting. There's a couple of really good graphs in there of just like area under the curve between untrained and trained lifters, and talking about like the adaptation that you get with the minimal dose of stress. And I've actually pulled this up with some of my patients because there is one chart that shows that like any stress in the system at all will cause an adaptation that's under the curve. And so sometimes they're just like showing people like if you do anything that's movement or directed at some one of your impairments that you care about that's somewhat related to what you want to get back to doing, whatever that is, I have to make sure that they know what they actually want to be able to do. But just showing them that graph of like anything you do in that direction at this point will be beneficial, and then you can kind of like play off of that rolling forward, if that makes sense.
Is that are you doing your rotation there, or are you now a actual clinician there?
No, just doing my rotations there.
feel like you've been there forever.
I'll be here till the end of the year.
Wow. Would you want to stay there, or would you want to go different route? No.
Yeah, no, but it is really beneficial as far as a learning tool, just because the patients that you see do have so much going on, and so frequently we are the point of contact. Like even yesterday, a guy, younger guy, had come. He failed during like a PT test and hurt his knee. Went to the ER upstairs. And the doctor saw him, told him he tore his meniscus. Came to us, and I'm like, looking at his knee, all we were told is, hey, fit this guy for crutches and give him a knee brace. But, I looked at his knee. It was like, yeah, your patella is like 5 centimeters up and to the left, like it's way out there. We should probably do something like that. Sure enough, he had a huge patellar tendon rupture, and no one had looked at that. So like even we've had cancer stuff, we've had a lot of really scary comorbidities just because no one else is catching it. But I think, in that benefit, once you've screened for, a lot of the red flags and really dug in with questions, it really just comes down to what thing can you do right now, today, and for the next week that you haven't been doing. And if it's physically active in any way at all, tend to see people get better pretty quick. So like I guess in regards to like physical activity, that's for me, like I kind of tuned in late to you guys, but someone was talking about with the idea of finding, I think it was you, Alec, that was talking about like your coworkers, about how they want you to find like real specific things to do and like really palpate and really get down to the special test of what goes on in the low back. And it's like, who cares, man? If they're not moving at all, like why the fuck are you going to care about like their apophyseal joint not gliding properly at L4 to L5? It's like, what? Like they can't even sleep at night. These people think that they're just down and out and are so medicated, and they're ready to just to give up on life. And you give them two little movements that just help them walk to the mailbox, and all of a sudden their life changes. Like that's huge. That's huge for them. So anyways, just becoming a huge believer in this physical activity stuff, just because in this particular population, it is almost more meaningful than what you see in maybe the young athlete type population that a lot of outpatient ortho students really end up wanting to work with, but maybe don't end up working with as much.
Yeah. After I've done evaluations before, sometimes I'll just send them on their way until the next visit and say like, yeah, why don't you just go for like 10-15 minute walk a day for right now, and when you come back next week and we have a little bit more time, we can kind of try to work on a little bit more specific stuff. I've had coworkers like, why aren't you teaching them how to contract their TA and all this, like that's a whole nother rabbit hole in itself. But yeah, I actually did one rotation at the VA as well, Audie Murphy in San Antonio. So I don't think we were at quite as front line as it sounds like you are, but it's definitely, there's like no such thing as like an acute injury for that place. It's like everything 10, 15, 20-year histories, it seems like. But one thing I was also hoping we might touch on is discussing this sort of stuff with patients who maybe have like a really physically demanding job and kind of already perceive themselves to be meeting those guidelines based off of like what they're doing from day to day. But then when you kind of question them a little bit more, it's like, well, they're kind of just like, standing around for like 30 minutes at a time, then maybe like walking around, and then maybe like one patient in particular I've been working with this past week has like 100-pound ladder that he has to carry around. And so it's like 2 to 3 times a day, he's picking up this very heavy object. But then like most of the time it's kind of like climbing up the ladder, coming back down the ladder, walking around a little bit. And so I was kind of trying to have this sort of conversation with him this past week about maybe like starting with something small and trying to build up from there. And I guess we just didn't connect on the same level because he's kind of already perceiving that, well, I'm already doing like lots of physical activity. I'm already like doing these sorts of things that you're kind of asking of me. And I feel like it's just going to like make my thing that I'm coming to you for worse. So I don't know. I was hoping we might be able to talk about that a little bit as well.
So in those instances, I tend to go down some of the other sleep conversations a lot sooner too. But in the same regard, like, okay, so you got to move a 100-pound ladder a few times a day. Well, over time, like, it's going to get closer and closer to where that 100-pound is a maximum effort. So, like, shouldn't we try and get it to where you're able to move 200 pounds pretty easy, because that makes the ladder lighter all of a sudden? And, sometimes for myself, I'm like, who do you think has an easier time moving the ladder? You at 165 pounds or me at 240? And most people are like, well, it's probably not that hard for you. Why is that? Well, because you're bigger and stronger. Okay, this is why I'm trying to get you bigger and stronger. So, and just kind of like finding different methods out of it. It'll be interesting. Like, so I haven't worked Gen Pop in the last 3 years, so I just haven't had as many reps on those conversations. So I'm sure when I get back into it, I'll screw up a few of them.
Yeah, I feel like I've kind of talked about it a little bit in that way as well. I think it's kind of getting to him. It's just like picking at it a little bit at a time. I guess nothing, comes in the first session or even the second session or third session. It takes kind of weeks of working at it. But
man, you can't fix people in one visit.
Unfortunately not. No, I'm not.
You're never going to make it as an Instagram PT.
Derek or Alec or Quentin, since you all actually work with patients, has there been an instance where patients say that the only time they are physically active is with you in the clinic? And like, how do you go about navigating that? Because you are obviously helping them be physically active and they're in the clinic, but has there had to been conversations of creating kind of that like independence towards how they do these things on their own, or the harsh reality of you're not going to be with your PT for the rest of your life? Has that ever come up with any of y'all?
You guys want to go first on this? Because my answer is basically I'm just an asshole.
Yeah, I would say I have that come up fairly often. We work with a lot of elder patients, kind of geriatric population, and a lot of them, like when they're coming to physical therapy, sometimes, not a lot, but I would say a handful. It's like the first time they're doing physical activity sometimes. And I don't know, I guess just starting with what they're doing in the clinic and then trying to give them a little bit more independence over time. And so like after maybe a week or two saying, okay, so like we've been doing this stuff in the clinic. What's your confidence like with, or how confident do you feel trying this at home on your own? Kind of gauging that sort of thing. And if it seems like too much, then saying, okay, well, what if we break it down and make it a little bit smaller? Like, how about just working on this right now and then trying to either like over the weekend, why don't you see if you can get this in a couple times, or if I'm not going to see him for a couple days, so how about take off tomorrow and then on Tuesday, give this a try, see if you can go through what we've been working on here, and then take another day off, come back that next day, I'll be seeing you and we can kind of talk about how things went. I guess whenever people are like starting at that really, really low level, that's usually how I'll do it, and try to install confidence with whatever activity it is we're working on in the clinic first, so that they feel comfortable doing it on their own at home. Does that kind of answer what you're talking about?
Yeah, for sure. And like I saw that with when I was up in California, when I was a personal trainer, it was a lot of this independence with their trainer. If I can only work out if I'm with my trainer, and I see that it probably goes a lot to the PT point of I can only do these rehab exercises, or I can only be, like, have guidance when I'm under like the watchful eyes of this provider. But then there's real no kind of like letting go of that relationship and that confidence and understanding that inherently I don't need you anymore. So I've seen that a lot with like personal training world, where they feel dependent on that trainer, and if they don't have them anymore, they don't know what to do. And I think it's probably even worse with PT, because you may see your PT for only a few weeks or a few months, and then inherently you may go back to absolutely nothing. So yeah, that for sure answers my question.
To Kevin's question, anyone who suggests to maintain them at a higher visits per week, I don't agree with that by any stretch of the imagination. I try and make it clear in my initial conditions that we're not going to be friends for life. Like, this is going to be something you're going to have to do on your own. And like, I'm pretty notorious for like being very loud in clinic and even in the waiting room, and like patients are coming up and my first question is like, did you do your homework, or like, what have you done since last time? And like, I'm going to put some accountability on them. And I think being able to, and once again, like, this is my personality. Other people are, you're going to have your own shtick as far as ways to really convince people of it. Like, I highly doubt someone, Chris, I don't think you could pull off my shtick because you're too nice. And it's just like, you're going to find what works for you. And, but like, you also have to like be willing to find what works for you. And you're going to try different things along the way. But like, I try and be as explicit up front that I am not a long-term solution.
Have you had backfire from that at all?
Oh yeah. Yeah. On more than one occasion. But like, I also have been really lucky in the 2 clinics I've worked at to where like, and I think this is often underappreciated in physical therapy. Like, the coworker who I worked the closest with, actually the 2 who I worked the closest with at Stanford Children's, were both like very nice individuals. So like, if someone needed a little bit of TLC, go get on Tim and Steve's schedule. But it worked both ways, because if they had the people that just weren't listening to them, it's like, well, we're going to go put you on Derek's schedule. And it's figuring out how to match those personalities together. And, you know, I think like a lot of people, we don't have those conversations about how much our personalities like really play into the overall interaction out of it. And like, knowing where your limits are.
What about from the pediatric standpoint? Obviously, when you're at Stanford Children's, a lot of the kids you were seeing were almost super.
Sorry. I'm going to mute myself for a second.
Okay.
Sorry.
No worries. While he's muted, Quentin, do you want to answer, or do you have any input on that from the VA?
Yeah. Which part? The part from before?
Yeah, like if you've had patients come up to you and say that like, really the only time I feel comfortable being physically active is with you.
Yeah, so that's happened a couple of times. I guess I come at it from more of like I try to like educate them more than tell them what I want. So like, I'll just explain to them that in the grand scheme of things, I am seeing you for 30 to 45 minutes, maybe, right? That's this much time. And at the VA, at least how it usually works is you see a patient once every 3 weeks. That's par for the course. Once every 3 weeks. Right now, with how it is with the COVID stuff, and I'm in California, so people are losing their shit over it still, which is stupid. But anyways, we see patients, maybe a little more frequently, once every 2 weeks, maybe once a week, and we have a little bit longer visit with them. But I still explain to them, like, if I'm seeing you this much time, you're spending, literally orders of magnitude, just hundreds of times outside of this, right? Like, if we're here, your day and all the other time is all this other area of this pie chart, and I try to be very clear to them that you being here with me is just for me to assess how it's going, to give you a couple of extra tools to work on, to give you some guidance and some education, but you heal you. Like, you're the tool that is going to make yourself better, not me. And I guess I try to give them the option of like, you can keep coming in here, because with the VA, like, they get, especially if it's 100% service connected, like if it's connected to their injury that they got during wartime or training in the military, like they have unlimited access to be a very high utilizer of the system, right? But I guess I try to explain to them that like, they have the freedom to choose that option, but it will never be enough, and that they can keep going down this path. But I try to let them know up front that what I do with them will never be enough. And I think that conversation has gone mostly well, just kind of empowering them to realize like they are the ones that are going to be healing themselves. And I think just because my treatment philosophy, like I don't do a lot of hands-on stuff. I don't do the manual therapy stuff. I don't do dry needling. I don't do the cupping that a lot of the other therapists in the clinic do. And so, like, I think they get these patients that are so addicted to their hands, the therapist's hands on them, and the needles and the cupping, and they just want to sit there and be pampered on. And I think when they come to me, I don't do that. I rarely even put my hands on the patient because I know that like I'm not the one going to be making the difference for them. They are. And I think it just already kind of cues them into like, if you come to see you, that's kind of what you're going to get. And if you don't like that active approach, you can go see someone else and I'm not going to be offended. But I try to let them know just right from day one that like, even during the eval, that everything I'm telling them or giving them is just to educate and to guide them, but that it's up to them. It's going to be largely up to them to get themselves out of this cycle or this rut or whatever thing they're dealing with. And then we just work on finding things they care about, finding on things they want to be able to get back to doing, really honing in on their goals, and then kind of reverse engineering how we're going to get there. And I don't know, it seems to work a lot better than trying to like chase the specific diagnosis impairment on the very minute joint space of something, you know what I mean? So I hope that helps with that answers.
Yeah, I would really agree. I think setting expectations up front can be a huge help in the long run at kind of letting the patient know what they're going to expect out of it. And I also think, kind of to speak to Kevin's question a little bit as well, sometimes PTs use that as a justification, or at least some of the people I work with will kind of use that as a justification when the patient's not super independent with their stuff, as a reason for keeping them longer or seeing them for like a longer period of time. I don't know. Maybe it's just my opinion, but I was curious what you guys think about it as well. Of if the patient is kind of not really following through with that sort of independence, kind of not just like discharging them, say, well, you're on your own, but I don't know. I kind of feel like there's other people that we could be getting to that we could maybe make more of an impact in. And so I kind of see people for a certain amount of time. And then if what I'm trying to help them with is not really resonating with them, either recommending they go to see another PT that I work with or kind of trying to end it there. Like we've been doing a lot of chart audits lately at our clinic, and I see PTs that have patients on their schedule, like not for like, ACL rehab or like Achilles tendon rupture or something that they're going to be seeing you for like a little while. And they got like 40, 50, sometimes as many as, like 50, 55 visits with a patient. I'm like, how is that patient gaining independence with anything that you're doing? That's like, it just blows my mind.
So I think it is interesting to talk about those cases. And I would be interested, like at Stanford, I would say outside of my like post-op rehab, I'd be willing to bet I averaged about 6 visits a patient. But now I'm seeing a lot of acute stuff that's like, hey dude, walk it off. But I definitely had like at least 2 kids that I was over 40 visits on, and they were overly sports specialized, like psychological comorbidities, and like really I kept them in just because they needed to unload once a week. And it wasn't necessarily that like they're not going to change their behavior. They're hurting all the time because they're swimming 20 hours a week. And so like it was almost a wellness check. They came in and did their exercises, but most of it was us having like reflective conversations over how the last week went, how they're sleeping, what we may need to change as far as the recovery side of it. And like I build 1 unit. So like it's not like I'm like crushing the bank. And she was in there for probably 45 minutes most of the time, but like she knew her exercise program. And it was just like, and it sucks because I think sometimes we do a little bit too good of a job of getting people to buy into what we're selling. And then it's like, how do we cut ties with that? And like in instances like hers, I don't really have a problem of like, if you're that weird teenager who has no social support skill or system and like just needs to go unload on somebody every now and then. And it's probably actually pretty analogous to what Quentin's talking about with some of these guys at the VA. It's like, when's the last time someone just sits there and listened to them? And like, I don't mind sitting there and like letting you unload for a little while. But I mean, this same girl showed up for one appointment and had slept like 3 hours and went to practice. And literally her treatment for that day that I billed nothing for was I made her go lay down on a plank and take a nap for an hour. I was like, this is more important than anything you're going to do in this room. But it's setting that precedence of like, it's okay to slow down and chill out for a while.
The question I was going to ask you earlier, with at least the patients when I was there shadowing you, a lot of times the conversations were about pulling back in a sense because they were so hyper specialized and spent so much time. But in the scenarios of maybe you had kids who came in that were very sedentary, was it the do you think it was more of a productive conversation with the kid or the parent, or probably just both of them, of like, how do you get across these like behavior change and things if like the parents that you see really aren't instilling that in their kids? How do you go about those conversations?
I mean, how much did you listen to your parents when you were a teenager? You probably listened all the time because you're a good kid. But like, you know, your average teenager is going to be a little rebellious towards the parents. A lot of times I'll start with a kid and be like, you know, we need to be doing X, Y, or Z. And like the parents can enforce some of it, but like in the same time, like I want it to be up to the kid, not the parents sitting there cracking the whip the whole time.
I had a question for you, Derek. So I think the kickback that I guess I experience sometimes from other therapists or students or whoever, with finding like real specific things, or even billing for very specific things, or your treatment is very specific to an impairment, is the idea that they need to like look good or justify themselves to the physicians or the orthos that referred them. Like they're so concerned about the reputation of physical therapists not just being like a glorified personal trainer, and actually being like doctors of physical therapy that can do more than just hand out bicep curls and rows to people. And so I think sometimes like I get kickback on like documentation stuff because they want to see that I palpated all these specific structures and that I found that there was a innominate upslip on the right side and rotated here, and they want all this really really deep medical lingo just to like, I don't know, puff themselves up a little bit to the physicians because they are trying to be respected in the system. And I don't know if you ever have experienced that, or how to tread those waters, or how to respond to that kind of idea.
I mean, that's their own insecurity. And like, if that's how you're justifying yourself to a physician, is by trying to use big words, then like you're probably not doing a good job of justifying yourself to the physicians. Like that's like, they're people too. I'm married to one. Trust me, she's not a genius. Like, it's like, I don't understand this need to impress through superfluous vernacular. And that's intentional wording on my part right there. And it's like, cool, you can church it up, but like, one, does it exist? And two, does it matter? And like, if I think people forget, and I would be interested to hear how often these PTs interact with physicians, because like through most of my career, I've had very, very close relationships with physicians. In fact, in Florida, I had a gym at my house that all the orthopedic residents came and trained at. If you want to talk about a great place to go learn, just have all the residents come lift at your house. But like, I think people assume that using these big words make people think you're smart. But like, I've had many conversations with physicians where, like, on Wednesdays at Stanford Children's, I worked in physician clinic the whole day, and you would get these PT notes that were full of dumb shit like that, and we would sit there and make fun of the PT. Like, I'm sure they feel good about themselves, like but like, just because you can use a big word doesn't really mean shit. Like, I get on to Mike Ray all the time because no one in the history of ever has used the word elucidate in a normal conversation. Which is funny because he just texted me. But you know, we are there to be communicators, and like, it's like that kid that tried too hard to impress everybody in high school. I feel like is like a lot of what PT is. It's like, hey, look at me. I have a doctorate. I can use the big words too. And like, I think at some point we need to realize there's nothing really special about us. And like, what's the difference between us and a personal trainer? Well, a personal trainer has direct access. A personal trainer can sit there and talk to somebody for as long as they want to. Like, fuck it. Personal training sounds kind of cool sometimes. Like, it's this whole, like, the fact that a PT sits there and looks and says what makes us different from a personal trainer, as though they're denigrating a personal trainer, that person can go fuck themselves. Like, that person's working to master their field as a personal trainer. Why do I need to sit there and shit on them? There are plenty of stupid PTs I can shit on instead.
Yeah, we had that one professor in particular who would ask us a few times, how do we differentiate ourselves between personal trainers or chiropractors or anything? And it rubbed me, and I know a few other students, the wrong way of, one, why do we need to differentiate ourselves between other people? And two, like, we're inherently not that different in the grand scheme of things, from just like a smart, like, education and training and like what the end goal is perspective. So it is like a really weird kind of ego within the profession or within certain clinicians, like trying to provide this value that is like unnecessary for you to try to prove your worth.
So maybe let me ask you this, Derek. So if you ever are with that, or even just now we can come full circle back to like physical activity. You're seeing someone, maybe you got a referral from somewhere for some kind of specific thing, or even if, whatever. And that kind of is your goals that you were saying that you wrote, patient will meet 150 minutes of moderate physical activity in the week. Are there any kind of hoops you have to jump through, or things that you try to check off or do in order to some kind of justify that, not just to insurance like you talked about, but also just to justify that the referral that was given to you is being appropriately handled? Does that make sense?
And I think, once again, I can only speak to the two places I've worked. And I had very close relationships with my physicians at both places. And I think like that's something that like we can't overvalue. Like we need to have these relationships with our referring providers, because one, like if they're doing something stupid, odds are I'm going to say something about it. And it's better to like know the people you're having these conversations about. I have never been in a situation, and I'm sure those of you who've treated patients with some frequency, like there's always that one physician that you get the script from and you're like, oh God, here we go. And like, you can talk to that physician and try and change their mind and have those conversations. And sometimes it works, sometimes it like doesn't. So, but like at Florida, by the time I left Florida, I would say probably 75% of my caseload were direct referrals to me. And that came out of building relationships with physicians, and like, and going back to what I said earlier about like, if somebody needed a nice therapist, they'd see Tim. If somebody needed somebody with a little bit more boot to ass, they'd see me. And our physicians knew that. So like the physicians in Florida would be like, oh, this is a Tim special, this is a Derek special. So like you're even getting more granular in where things are going out of that. So it is building those relationships, but like I don't give a shit if I ever impress a physician. Like, and I know that sounds harsh, but like there are plenty of other physicians I can get along with fine. And if they want to try and have the ego stroke thing, bring it on. I got citations for days. And I think that's part of it, even out of this whole like insecurity, what makes us different than a personal trainer, impress the physician stuff is like, if you can back up your shit, people tend to listen to you. Like my first day at Stanford Children's, like literally my first day on the job, they were touring me our facility, Chris, the gym that you were in, and the physician who I worked the closest with was actually just getting onboarded too. And we walked into the room, and her first statement was, "Is this where you guys do the kinesio taping?" And without even like a pause, I was like, "We don't do that here." At which my boss about stroked out. I was like, "We're not going to do that." And just lay it down in the sand.
Yeah, I remember some interactions you had with some parents when they asked about kinesiotaping. I think you asked, have you ever cooked a piece of pork? It was some like cooking question. It was great.
I mean, if I had $1 for every time I threatened to throw the Alter G out the window during my 3 years there, I could probably make a house payment. So
I guess kind of going off like the referral sourcing and sort of like continuum of care, and then going back to what Alec mentioned, like at discharge, you know, like even holding on to a patient to try to encourage that behavior change. And this might be a little different for Derek working with like a sports youth population, but I was wondering, like, as far as like setting them up, like while in care, like while actively seeing you, checking in and seeing if they're, you know, like getting a gym membership or like getting more connected to like community resources. I was just wondering if anyone had any like experience with that, positive or negative, or do you guys encourage that? I was just kind of thinking on that other side of the treatment spectrum.
I mean, I think COVID and this movement towards telehealth has shown how bad a lot of PTs are at talking to people. Just because like when you're forced to have these interactions face to face for a while, like you have to have something to talk about. And you started seeing the like, well, what do you have access to? What can we possibly do right now? And I think this is part of the problem with like a lot of the propensity is like, I need to go out and then I'm going to do my certification, whether it be McKinsey, Maitland, pick 3 letters. And you go so far down this rabbit hole to where like you have like this view of the world. Whereas like right now it's been like the generalist heaven, because like, I mean, it's, if you tell me you have a kettlebell, 2 bands, and a 5-gallon bucket, I can design you a workout. And like it's being able to look through things like that and think through the problems, versus like if you're a therapist who's predicated on like your apophyseal joint isn't gliding, like, well, what the hell do you do?
I have like a generic question, like, what do you guys ever have those patients? Because I used to tech for a hand specialist, and you have those patients that come in that, whether they're like an artist or like their job doesn't require them to be like any physical activity at all. Like, do you try to frame like pushing physical activity, like we know all the benefits, into those conversations, like during the evals? Like, let's say your patient doesn't have any comorbidities, they're fairly healthy, and like they're like an artist, but like, do you still try to, I guess, not manipulate the conversation, but based off their goals, like whether, let's say they have a grandchildren and you're like, do you ever like try to manipulate, like, oh, like, do you want to like still be able to pick up your grandchildren? Like, you don't try to say like, they may not say specific goals, so you're trying to like dissect what they're trying to tell you during the eval. Do you like push for physical activity all the time, or do you have to pick and choose based off of like the patients that you guys get?
I mean, I think it's specific to every person coming in. It's not like I'm going to unload on somebody the first time out of it. But I do always ask the questions of like, so what do you do for fun? So what do you do to be active? Like things of that nature. And if the answer is nothing, it's like, I mean, if you've worked with teens, I'm, what did you do since last time? Nothing. What have you done that's fun? Nothing. What have you watched on TV? Nothing. All right, you're a 13-year-old nihilist. I get it. Like it's like, I've on more than one occasion I put bans on the word nothing, fine, and good in my clinic. But like it forces you to have these conversations that are actual conversations, as opposed to this like there's this two-step communication that goes on a lot of times where nothing really transpires. What's up, man? Nothing. How about you? Nothing. Oh, what have you done since last time? Oh, something. And it's just like there's no substance to this whatsoever. Whereas like a lot of our job is to find those conversations that have substance to them.
Yeah, that's really good, really well said, Derek. I think when you were saying that, there was a patient yesterday, kind of that same thing. Didn't really have any real physical goals. Nothing, was really pinging off in what he was saying that was really that much, any kind of active thing. So just started asking him about his family. Said he had, kids and grandkids in the area. And then I just started kind of traveling down the road of like, oh, cool. What do they like to do? You ever go hang out with them? Fun. Where'd you go? Where'd you guys go last week? He started telling me stories about things that they were doing. And I just, asked him kind of randomly, hey, when you guys went to the beach, did you get to play with them? And so he's like, no, I just had to kind of sit in the chair, and just kind of watch him. And I was like, oh, yes, that works. But would you like to play with them? And he just was kind of like, well, yeah, but I'm old. I'm too old for that now. And I was like, well, what if I told you, like, maybe we could get you to a place that you could play with them just for, even if it's just a few minutes, how would you feel about that? And it just things like that he kind of liked. So I guess less manipulating, because if you come at it from that angle of, well, in the back of my mind, I want physical activity and I need you to be active. I mean, in reality, and I think Derek, you'd agree, like, I just want people to lift. Like, can I get you in a squat rack today? Like, in the back of in your mind, sometimes you think these things. And so if you come at it from like a manipulative, like, how can I get you to do this thing I want you to do? That usually becomes a not a very good treatment, or at least you don't really get on base with the patient. They don't, want to listen to you, and you actually don't know what even really truly matters to them. So, going back to your artist person, I would, wonder, what kind of things they like to paint, how long it takes them to paint. I don't know what their, pain would be, but like give it like 70% of people, are going to have some kind of low back pain or something. So are they sitting? When they're painting, what can you find to just add in their day to allow them to paint more? And if that's going for a walk instead of just sitting in their little stool painting their picture, that might help them paint more. So again, like, you kind of, it was a little bit short-sighted and maybe sort of manipulative in kind of a way, but at the same time, you're doing something that's meaningful to them. If it helps them paint more, and finish their painting, like, that's a win for them. And if it's a win for them, it's probably a win for you. I don't know if that helps, but that's kind of how I think my mind thinks about it.
I just figured like since we know so much of the health benefits of just moving, like I guess I wonder like how can we have those conversations? Like when and like how often should we be having those conversations? Like because I know like it's specific to the individual as well. So it's just like, is that something we should always try to like say in the eval, or like I know it's up to the patient's goals, but I was just like curious because yeah, I'm with Kevin and a lot of us here are still students, so we don't have a lot of patient interaction. So it's just like I guess how often should we be promoting such an easy not easy thing, but such a low yield thing that patients should be doing?
I think we should be doing it very often, but I've joked for years that like my primary concern after ruling out red flags on an evaluation is just getting the patient to like me. And like, if I can check that box, then I have a much higher likelihood of affecting actual behavior change versus like, once again, like we could come out of the gate and be like, well, you need to do X, Y, and Z. And like, once again, you're objectively right, but no one's going to listen to you. So that's that part of like, how do we get people to listen to us is really the imperative side of it.
What about if, based off of just you being in school and understanding some of the curriculum from a PT perspective, how would you reframe things from like a physical activity or a guideline perspective to have like new grads mindset shift towards some of the things you've been talking about?
So I sit on a panel at Florida, God knows how many years ago now, regarding like how to get good students at the university. And I never saw the study, and I'm really sad because I've like acknowledged this fact God knows how many times in my life now. When they were talking about what makes a good PT student. And it's not, unsurprisingly, it's not GRE scores or what your undergrad major was. There were two things that really correlated with outcomes. And one was having worked as a rehab aide, which makes perfect sense because you actually know what you're getting into. And the other one is having worked in service industry. And like, if you want to learn person-to-person interaction, go work in a bar. Like you'll get more reps there than you ever will from sitting in probably like even a psychology class. Like, I mean, I worked as a bouncer for 5 years. If you want to start learning negotiation skills, is a pretty good place to start.
More so like, how would you shift the education from like a physical activity perspective?
Oh, I think TheraX is a joke in most PT schools.
Yeah.
It really is like this whole joint by joint approach misses the boat. It's like, if you know, once again, that like 80% of society is not even active, like I don't give a shit how many TheraBand yellow external rotations you do. And I think we need to be talking about it more from like movement, and then starting to talk about like dose response. Like, because if you think about it, like TheraX is essentially our pharmacology class. Like that is the thing we deal in that really affects physiological change. But like having conversations, I always think it's hilarious that it's like, oh, 3 sets of 10 is like the PT dosing. And like, well, you didn't tell me the intensity nor the amount of rest in between sets, because I can give you a workout with 3 sets of 10 that'll crush your fucking soul. I guarantee you, if I went on barbell medicine with some of my athletes right now and wrote out 3 sets of 10 back squats at RPE 8, I'm going to get some text messages later today telling me what I can go do with myself. But like, it's hilarious that like we stop there and we don't even qualify how hard what we're doing is. Like, I would love, like, if I were to do a PhD, the first study I would do would be to just completely do a randomized control trial on myofascial decompression, just because Chris DePrado can die and burn in hell after living in the Bay Area for so long. Like, and I think for the soapbox real quick, we don't appreciate the regionality of a lot of what goes on. And this idiot was up at UCSF hawking cupping. So the entire like Bay Area cups. It has fuck all to do with evidence. It just is the guy who is the great salesman is up teaching the class up there. And when confronted with, well, why don't you publish a study? Well, you know that takes time. Well, motherfucker, you work at an academic institution. But like the second part, the actual non-spiteful side of me, would love to do a study where you go ask session RPE to patients and see if that correlates with outcomes. Because I would love to know how many people leave a PT session. They're like, what's your session RPE? If 0 is the easiest thing ever and 10 is maximum effort, like I would be willing to bet that 70% will be under 3. And if that's the case, like, are we really doing a decent job of dosing in what we're doing? Like my front desk ladies at Stanford Children's laughed. They're like, we always knew when it was your patient because they were the ones who came out covered in sweat.
And Derek, I don't want to, are you still on the soapbox? I was going to kind of build off that.
I'm good. I just needed to
cool.
say the product can go fuck himself.
Solid. Okay. So kind of on that, like we've in our classes we're taught about like a percentage of their 1 rep max, but it's like it's difficult to find, I mean, like guesstimate what their 1 rep max is, and then to even define like what resistance training is. And I kind of had that question. I mean, we know like the physical activity guidelines, but for me, I guess it's kind of tough to like define, and I know it's kind of a spectrum, but like define what is resistance training depending on the individual. I don't know if any of you guys in practice maybe have something on that.
Next time a professor says something based off a percent 1 RM, ask them the last time they 1 rep maxed any patient on their schedule. But I think like the movement towards RPE has been very handy out of that. Because if you look at it, like I almost substitute RPE for the pain scale at this point. Because what I'm trying to do is change your perspective on what is hard. Like, well, 2 weeks ago, you did a set of 5 at 65 pounds at RPE 7. Now we're at 95 pounds. Like, you know, we're damn near 50% improvement. But like, you know, they don't have the motor control to where I'm going to 1 rep max them anyway. And like, there's no utility in that. So like, I have other ways that have evidence as being as, if not more effective.
Yeah, I like, and just kind of on that, it's like we were given these patient scenarios with comorbidities and stuff like that, or maybe even just some sort of injury. And in my head, I was just, how do you even safely try to like find that? But obviously RPE and like their confidence in how those reps felt is probably a good place to start.
Yeah. I mean, that's typically where I start with that all the time.
Yeah, I feel like I didn't really think about this until just now, but I feel like whenever I'm working with patients, I kind of break the way I approach an exercise or a movement or something like that with them, like I guess in 2 ways. One is kind of more like building confidence and comfortability with an activity in general. And then the second one would be actually starting to like load that activity. As far as like finding percentage of 1 rep max, like when you're doing stuff in the clinic, I use RPE a lot, but we have like a little kind of like a handheld dynamometer crane unit that I can have them like stand on top of and perform like a isometric pull in it at like mid shin. And so usually once they feel comfortable doing something like a, 10, 15, 20 pound kettlebell lift from the ground, and they able to do that sort of thing for a little while, then I'll have them, like one morning we'll come in and I'll just say, okay, let's like pull into this as hard as you can, kind of see what that is. And a lot of times they surprise themselves when they pull, like 120, 130 pounds. And we've been lifting like a 20, 25 pound kettlebell, and they like thought that was hard. So then I'm like, okay, well, how about, to truly like build strength, ACSM said we should kind of be doing things like 50, 60, 70, sometimes 80% of your one repetition max. What if we try like at the lower end of that today? Like, let's say we try 50% of that. So then like, whenever they see like 120 pounds on there, like 60 pounds is like, okay, that's like no big deal. I could probably try that. And then they do perform that. And when they're done with it, you can kind of ask them, okay, so like, how'd that feel on that RPE scale that we've been talking about? And that 25 pound that they had been saying was, like a 7 or an 8. Now all of a sudden, like this 60-pound thing is like really maybe like a 6, 7, 8 to them. And they're like, I don't know. I found that that's kind of the way that I do things sometimes. And it's usually like a really big confidence builder for patients. Is that similar to how you guys do it, Derek, Q?
Yeah, I mean, I was a big fan of using the black bumper plates at Stanford Children's because nobody knows how much they weigh. And like, even with the kettlebells, most of the time I would never tell people to go pick up the 26 or the 35, go pick up the yellow one. And like, because you don't know what hard is.
I think just within the sessions, I usually use the RPE. Like I'll tell them, like I'll give like, let's say I give them an exercise that I know is going to be pretty challenging. And I'd say, hey, I want you to do repetitions till you feel like you're at maybe a 7 or 8 out of 10. If 0 is nothing and 10 is literally going to crumble on the floor, or you can't do the movement properly anymore, I want you to do that. And then if they kind of like give me maybe a weird look for that, I say, okay, go until maybe you feel like you can give me 2 more really good reps. And I want you to stop before you hit that point. And that, it seems like, even after 2 or 3 sets of that, people are able to kind of judge like, yeah, I think I've got maybe 2 more in the tank. And then it just becomes like, every session or at home, I just tell them to shoot for that 1 or 2 more reps over the next, 2 or 3 times they perform that exercise or that thing. Like you said, if it was just picking something up off the ground, like I've had several folks right now, they don't have weights at home. I'm like, well, do you have a milk jug? Okay, go fill it with dirt and pour some water in it. Now you've got a weight at home, and just bend over and pick that up. And then like just trying to progress that over time. And then, like you said, when they come back, all of a sudden, what was an 8 out of 10 before, and I only have 2 more reps. Now it's like they can just go for days, and now I have to find something that's harder that they can do with like no equipment at home. You know what I mean? But yeah, I definitely think RPE, and I love what Derek said about substituting RPE for the pain scale. I very rarely ask what their pain is, just because, like, not that I don't care, but I just don't want them to care. I don't want them to be so focused on this numerical pain thing, and then every time they come in, it's like, oh, it's a 7 today, oh, it's an 8 today. Pain is just so subjective and such a bad indicator of what's all going on in their life, and it doesn't really tell me enough from getting a number, but I can tell a lot by how difficult an exercise looks or how hard they're reporting it is. That gives me a lot more feedback on, did I choose the right thing? Are they doing it at home? Does it work for them? Is it helping them meet their goals? You know what I mean? There's just a lot more information, data points available to me out of that number of RPE than there is out of a pain scale that's so nebulous anyways, and I don't want to get focused on the pain. Does that help?
Mm-hmm. Yeah. And to make things specific to a lot of times, like patients that I see, moms or like stay-at-home moms or something like that, the laundry basket can be a pretty effective way of kind of implementing that as well, because it's exactly what they're doing. Sometimes it's like causing them pain. So like, kind of like you were saying, just using stuff you have at home, just tell them like load up the laundry basket with as much stuff as you can find, and give that a try too.
do you guys, I also see like the benefit of like, self autonomy, like promoting like, here's your RPE scale, like teaching them about that and sort of having like a self-regulation on that side. Do you feel like that's kind of like a harder concept to get across in like the eval, or maybe that just comes with the reps, with how well that concept is received by patients?
I don't really ever teach it in the evaluation, other than maybe like Quentin was saying, try to go until you feel like you can do maybe like 2 or 3, 4 more with like good form. And then like maybe later on, a session or 2 in, I'll kind of start to use the 0 to 10 scale a little bit more. But I think reps in reserve kind of resonates with people a little bit better.
Scott Morrison talks a lot about anchoring, and I think that's really important when we're talking about RPE. My initial introduction isn't like, can you do 2 more reps? It's on a scale of 0 to 10. 0 is the easiest thing you've ever done, and 10 is, oh my God, what's Derek doing to me right now? And we kind of use that as our initial anchors and then work in from there. But I do a lot of times, like, especially on a leg press or something where there's just not a lot of constraints for technique. I will a lot of times have somebody do a set of 8 at RPE 8, and in the next session, I'll put that same weight on and be like, I want you to do it till you feel like you can only do 2 more reps. And a lot of times they'll get like 20 reps. You're like, well, that wasn't an 8. So
I can't remember who I learned it from, but somebody, I think, talked about like when you do have them, kind of similar to what you're saying, Derek, when you have them do an exercise, let's say first set 3 sets, or a set of 12, second set a set of 12, and then last set just go for as many as you can. And if they're getting more than like, I mean, I feel like a lot of times patients are like, I don't know that I could go higher, and then you have them do that last set and they go for like 20, 25, 30 repetitions, and you're like, okay, next time we're going to bump it up.
well, it's even like it is that area under the curve and what is hard. Like for most of society, 135-pound deadlift is insurmountable. And like for most of the people in this call, I'm going to assume it's not even like, it just happens to be the first stop on the warm up. And so it is that perspective out of it.
Yeah, and kind of maybe play off that a little bit. Going back to everything we were talking about at the beginning with physical activity too, it's like it is that area under the curve, and every progressive set or repetition that you continue to do past that initial couple just kind of continue to peter off in the available adaptation, right? You get like diminishing return for all the continued added volume, where most of that benefit happens in the beginning anyway. So it's kind of like going back to maybe even someone who is dealing with a ton of comorbidities or has very high fear avoidance, or just really can't get into a lot of positions. Just building volume in something they can do, and building that volume in an area that they can tolerate. I think most people, even if you have no training experience whatsoever, you can definitely get on board with what Derek was saying about the anchors, like from Scott Morrison. Of, okay, 0 is nothing, 10 is holy crap, I can't do this at all. I think even with people like that are, we treated 85-year-old vets who, have a hard time communicating and comorbidities just all over the board, but they can still get that. And honestly, kind of like what we were saying before, sometimes these people just need someone to listen to them, hear all their crap going on in their life, because not a lot of people just sit down with them. Like PTs have that eval time available just to sit down and ask them about how things are going and get like this broad life perspective. But it just seems like that, coupled with just finding an RPE or like something that they can do to build volume in the early phase, is going to work. And then it's no different for the athletes going forward. I mean, if you're a 600-pound squatter, you can't squat 600 pounds multiple times in a session, or even multiple times in a week over all your training and expect really good things to happen if 600 is your 1 rep max or 95. You have to build volume and all the lower stuff to continue gaining adaptations down the road. So I think it applies across the spectrum, and there's a lot of ways to do that. It's just finding, what matters to your patient. But I really like the anchoring idea. I think I've had good success with even people that have no training experience at all understanding that.
Does anyone have any other questions? If not, we can wrap it up here. Dope. Sweet. All right. Thanks, Derek. Especially considering you just moved across the country. I really appreciate it.
Yeah, what you saw me walking a minute ago is Chimera locked me out of the house, so I had to go walk around the house to get back in.
Did she just like hit the lock?
Mm-hmm.
Wow. She just wanted you to get your physical activity guidelines in for the day.
Yeah, she's just a stubborn dog. So.
Sweet. All right. Well, thanks again, Derek. I recorded this, and it's not going to be seen by any of my professors, but it'll be seen by some classmates. So I'm totally fine with explicit.
Yeah. Thanks for having me. Always a pleasure to get to talk to you guys. So, Quentin, I swear to God, I'll get back on a regular cadence for our journal club. I promise. So.
I mean, I always feel like such a nuisance email out because I'm like, maybe I'm the only one. I don't know.
No, it's just, you can ask Chris. He knows me well. It's kind of herding cats sometimes. So.
All right. Well, enjoy the rest of your day. Thanks again, Derek.
Yep. Thanks for having me, guys.
Thanks, guys.
Yep.